Bismillah ar-Rahman ar-Rahim. Invasive aspergillosis. Definition. The term invasive aspergillosis is reserved for the situation where Aspergillus hyphae actually invade tissue, hyalohyphomycosis. This usually occurs with severe immune suppression but is increasingly recognized outside of this setting. The port of entry is probably the lungs, but spread can be almost any area of the body. The species most commonly seen are Aspergillus fumigatus, flavus, Teres, and Niger. Mortality is very high. The source of Aspergillus is unclear but has been found in hospital water supplies. Pathogenesis of invasive aspergillosis IA includes the following. Alveolar macrophages probably normally destroy aspergillus spores. Macrophage failure may allow more spores to germinate, and any subsequent invasion with hyphae seems to be prevented by neutrophils. Inadequate neutrophil function allows invasion across tissue planes and may invade into vessels with infarction and further spread throughout the body. There is some evidence that the cytomegalovirus may inactivate macrophages, allowing spores to germinate. The fungal digestive the fungal digestive proteases do the damage rather than the host's limited immunological responses. Clinical features of invasive aspergillosis. The typical setting include fever, chest pain, cough, hemoptysis, dyspnea, and pulmonary infiltrate in a neutropenic patient failing to respond to broad spectrum antibiotics. Risk factors for invasive aspergillosis following chemotherapy, particularly provoking severe neutropenia below 100 cells per microliter, bone marrow suppression for allogenic stem cell transplants, advanced human immunodeficiency virus (HIV) infection and acquired immune deficiency syndrome (AIDS), immune suppression following transplant, infliximab or other anti-TNF alpha therapy, COPD, critical illness such as complicated influenza infection, rarely occurs with inhalation of a large number of spores in the apparent absence of underlying disease. This may be the first presentation. Immunosuppression, classically chronic granulomatous disease. Spread of invasive aspergillosis can occur anywhere with following well recognized signs: sinuses, paranasal sinuses, and spread into the brain, endocarditis, spread to eyes, spread to skin, papular ranging to ulcerative lesions. Careful examination and particular investigation may be needed to detect spread to these areas. Investigations. Isolate Aspergillus bronchial or branchial. Isolate Aspergillus branching septate hyphae from respiratory tract by sputum, expressed sputum 3% saline via nebulizers, bronchoalveolar lavage, BAL, transbronchial biopsy, TBB. Hyphae may be present when not the primary cause of the infiltrate. Biopsy from Biopsies from other sites, most convincing when acute angle branching, septated non-pigmented hyphae are seen, circulating levels of galactoman and exoantigen of aspergillus, 70% sensitive in immunosuppressed patients but lower in other populations, false positive due to some antibiotics, e.g., co-amoxiclav and piperacillin tazobactam. Serial sampling is recommended. Send Bell galactoman as well. Presence of B-glucan in serum represents fungal invasion but is not Aspergillus specific false positives due to blood processing and some antibiotics may affect results. Chest X-ray CT chest X-ray changes are usually non-specific. CT may show a halo of low attenuation surrounding a nodular lesion early on. An air crescent sign may develop on a chest X-ray, with air appearing at the edge of an area of consolidation. Usually occurs when neutrophil count rising and probably represents gradual containment of the infection into cavity, not unlike an aspergilloma. Invasive aspergillosis in the immunocompetent does not typically have angio invasion, so will not usually have the typical halo appearance. Ultimately, it is the clinical picture that dominates the diagnosis. Management. Reduction of the immunosuppression when possible. Consider colony stimulating factors. Prompt use of antifungals is essential for a minimum of 6 to 12 weeks. Intravenous voriconazole is the treatment of choice, may cause visual disturbances, deranged liver function tests, and skin rash. Liposomal amphotericin B is an alternative first treatment or first line treatment. Patients who are intolerant of voriconazole and liposomal amphotericin who have refractory disease can be treated with lipid-based amphotericin, posaconazole, itraconazole, and the capsofangine or micafangine. Some centers use oral posaconazole as prophylaxis when commencing substantial immune suppression. Surgical resection of the affected focus should be considered in some, as for example lung lesions contiguous with the heart or great vessels, chest wall invasion, osteomyelitis, pericardial infection, and endocarditis. The differential diagnosis. The differential diagnosis will be the large number of other opportunistic infections seen in immunosuppressed patients. Another invasive mycosis, Candida albicans, is now less common due to susceptibility or due to its susceptibility to fluconazole.